One of the biggest problem facing the women or obstetrician to deal with case of recurrent pregnancy loss or recurrent abortion or recurrent miscarriage. Today we are speaking in a simple way, not in a complex way like uh, big lecture. We just spot on important thing, how to reach diagnosis and how to manage cases of recurrent miscarriage or recurrent pregnancy loss. First of all, history taking is a very important because timing of the pregnancy loss is very important. If the pregnancy loss occur after 12 weeks in the second trimester with painless labor and short duration of abortion, and baby aborted alive for few hours, so we should think in incompetent os. Also, if the pulsation stopped especially after 8-week gestation, I should think in thrombosis or increased coagulopathy or thrombophillia or antiphospholipid antibody syndrome. Also, a lot of cases we have early uh, recurrent miscarriage or abortion because just failure to appear of pulsation or just failure to develop sac or just gestation sac developed for short period and then failure of growth or failure of appearance of pulsation. This is a lot of cases like this. So I should search for diagnosis for the etiology. First of all, we look for the mother. The holding the embryo is the mother. So systemically, is there is any problem or not? Simply, we should do TSH to exclude hypothyroidism. You should screen for diabetes mellitus, either pre-gestation diabetes. I prefer to do hemoglobin A1C, glycosylated hemoglobin A1C, better than to do just random blood sugar or oral glucose tolerance test to check if there is any diabetic event occur during period of gestation or not. Also, we should do thrombophilia screening or antiphospholipid antibody screening in form of antiphospholipid antibody syndrome, anticardiolipin, or lupus anticoagulant. If any of them positive, we should focus on problem in coagulation. So this is the cause of the recurrent miscarriage. We also do transvaginal sonography to check the ovary if there is PCO or not, and maybe the cause of PCO. We should also look for luteal phase defect, as in a lot of cases there is a problem in luteal phase defect. This is the endocrinological cause and coagulopathy or coagulation cause. Also, we look for immunological cause in some women. The problem there is antibody attacking the pregnancy. So, diagnosis of this cause is difficult. So, I prefer to treat any idiopathic case as immunological, especially if failed of anticoagulant therapy, as we speak later in treatment. Second thing, we should think in the uterus. They may be the cause in the uterus or local uterine factor. So assessment by transvaginal sonography and hysterobiography and better by hysteroscopy. We may find myoma, the cause. May find septum like this, the cause of the recurrent pregnancy loss. We may find small polyp maybe found intrauterine adhesion or Asherman syndrome. They may be cause either infertility or habitual pregnancy loss or habitual abortion and can be diagnosed and treated by hysteroscopy. Also, the concomitant os one of the local factor, but as we said before, it cause more in second trimester abortion and treated by cervical circulation. Last thing, we think in the embryo itself may be weak, but occurrence of recurrent with the same time the problem in the embryo is rare. So I delayed it to the third cause. I should think in semen analysis for the father to see maybe the problem in the father. Also, the main problem in chromosomal abnormality, but repetition of this abnormality in each pregnancy is rare and may occur, especially if the maternal age is more than 35 years. So, in conclusion, After we exhaust our self-investigation, if I don't find any cause, so the case idiopathic, and patient ask me how I will face the next pregnancy and what's your plan of management in the next pregnancy. I think it should be even with normal coagulation factor. You should give the patient anticoagulant to increase blood supply to the uterus and to ensure microthrombin care, which cannot diagnose upon laboratory level because there is a lot of tests for thrombophilia. So I inherit, especially inherited thrombophilia. So I cannot exhaust myself and exhaust the patient, and with high cost to do more than 10 tests for thrombophilia, like prothrombin G mutation or protein C or protein S deficiency, factor 5 leading, and a lot of cases I have a homocystinemia. So it's better to treat idiopathic case firstly by anticoagulant therapy and should be a high dose, especially if the patient failed in previous dose in previous pregnancy. If taken, for example, heparin 5,000 per day, should increase dose to 10,000 per day or 5,000 12 hour apart. If this failed or the patient has history of the failure of this of regimen, I should think in immunological factor as I said before, so I can give add to anticoagulant therapy, uh, drug like dexamethasone or immunosuppressive treatment. Lastly, if there is no response to the above measure, I should think in the fetus, the chromosomal abnormality, repeated chromosomal abnormality, and the case should be proceed to a sister production or XC with pre-implantation genetic diagnosis, and this is better for this case.